Today I'm going to take you with me on a home visit. I have a patient who had a quadruple bypass operation, and immediately as he came out of the surgery he started screaming with excruciating pain in his right hand. Anyway, they've done all kinds of tests and they don't know what's wrong. So I think that the median nerve was damaged a little bit. And as a result of not having a C-bar splint to open up that web space, he now has a web space contracture and he's got stiffness of his fingers. So I did do my energy medicine on him and he had a good response. And we'll assess the carryover when I see him today, but the problem is the web space and the finger stiffness. My colleague Paula Samara and I are busy submitting a paper to one of the journals with regards to using the CMMS technique with stiffness in the thumb. And we have come up with an incredible protocol. So I look forward to showing you what I do today and how a very unique approach for this patient is crucial, because if we do not cast him properly and we do not open up that web space and release that nerve and lift the skin and regain motion, he's actually never really going to regain function of his right hand. So let's see what we can do for him. So let's use CMMS Pro to help us. So I've entered the details of myself and the patient, and I don't have photographs, but let's use the mic button. This patient is a 49-year-old man. He had a quadruple bypass operation 4 weeks ago. As a result of the surgery, he came out of the anesthetic in absolute agony. He was screaming with pain, which clearly indicates there was nerve damage. The nerve pain has been treated, but now he has some residual joint stiffness. All the MCP joints are stiff, and he has a stiff thumb IP joint, he has a contracted web space, and he has poor MP joint flexion of the thumb. So we need to decide what is the best strategy for him. Hi Robyn, let me get into this with you. So M is 4 weeks post quadruple bypass. He came out of anesthesia and severe pain with suggested nerve irritation and compression and loss of range of motion in the fingers and thumb. Before we go further, how is he medically right now? Specifically, is he cleared for upper limb rehab? Are there any cardiac or anticoagulation precautions we need to factor in? And how do we apply and manage the cost? He's perfectly fine medically. He's at home, he's mobile, and he is fit and well. I would just like to review what literature exists with regards to current management of thumb stiffness, and then we will design a cast that tackles the thumb and the MCP joints. Good, so he's medically stable and mobile. That makes things straightforward. On the literature, the evidence base for post-surgical hand stiffness consistently points to the same principles that underpin CMMS. Low load, prolonged stress applied through active motion is superior to passive mobilization for remodeling cross-linked collagen. Aram and Madden's work established that stress modifies collagen shape and mobility when applied before excessive cross-linking occurs, but does not work against collagen strength once it's mature. At 4 weeks, M is right at the transition from fibroplastic to early remodeling, and this is actually an ideal window. The collagen is still young and responsive, cross-links are not yet fully mature, and the tissue will move well with the right sustained input. For median nerve-related stiffness specifically, the immobility component is the dominant driver here rather than intrinsic muscle paralysis, which is what makes this a CMMS case rather than a purely neurological one. So the stiffness is positional and disuse driven, compounded by post-surgical systematic inflammation and likely prolonged positioning on the cardiac table. So the contracted first web space is the detail I want to make sure we design around carefully. That's a soft tissue problem that needs its own solution within the cast architecture. Before we move to cast design, what patterns of motion are you seeing in the fingers when M tries to open and close his hand? Is he initiating with the MCP joints or the IP joints? Thank you for that. So he is initiating with the IP joints in an intrinsic minus pattern of the hand, and he is unable to do much motion of the thumb. So I do believe that we need to strategically position the thumb to help him achieve that range of motion. So we have a clear intrinsic minus pattern. The MCP joints are the stiff joints, the IP joints are doing all the work, and the cast needs to block what's moving and free what isn't. Exactly an indication for an intrinsic plus cast. Now the thumb is the interesting design challenge here. Poor MCP joint flexion plus a contracted web space tells me that we need the cast to hold the thumb in abduction and opposition, stretching the first web space while simultaneously positioning the thumb MCP joint in as much flexion as the tissue will allow. That way, the cast is doing two jobs on the thumb at once, elongating the contracted adductor pollicis and the first dorsal interosseous, and then driving the MCP joint flexion. Before we finalize the design, what is M's passive range of motion like at the thumb MCP joint? Specifically, can you get it into flexion passively? And what's the end feel like? That will tell us how aggressively we can position in the cast. So that's interesting. Now what I want to show you is that it's come up with the intrinsic plus cast design. So we know what to do with the fingers. We're just going to finalize what to do with the thumb. And we're still in the analysis stage. And so there are some peer review prompts happening here where we can actually in advanced mode challenge our own reasoning. So we can ask the AI to challenge my stiffness classification. Am I missing something? Could my end feel assessment be wrong? Push back on this, and what contraindications might have been overlooked. So this is only because we're in the advanced mode. Okay, so the web space is very tight. Thumb abduction is actually easier than thumb extension. But I do believe that with passive positioning, we can improve both. So that's really useful. So the web space tightening is limited extension more than abduction, which suggests the contracture is sitting in the abductor pollicis and the volar structures rather than the dorsal skin and first dorsal interosseous. So that actually works in our favor for cast positioning because we can place the thumb in abduction and palmar abduction comfortably and use the cast to sustain the stretch on the volar and the adductor structures while simultaneously driving the MCP joint flexion. So the fact that passive positioning can improve both tells us the end feel is still the end feel is still soft. So we're working with young, responsive collagen at 4 weeks, and that's excellent news. The hand will move well once the cast architecture is right. So here's what I'm thinking for the overall strategy, and tell me if you'll refine this differently. An intrinsic plus cast for the fingers with a thumb extension that holds the thumb in palmar abduction with the MCP joints positioned in as much flexion as the tissue comfortably allows. The cast does 3 jobs simultaneously. It blocks the IP joints from compensating. It drives MCP joint flexion across all 4 fingers, and it sustains a prolonged stretch through the first web space. Are you thinking a standard forearm-based intrinsic plus cast with the thumb incorporated, or were you considering a separate thumb component? Yeah, no, you're spot on with my thinking. I'm thinking that we need to include the thumb. It will be tricky. It's easier to include the thumb when we're doing an intrinsic minus, but we now have fingers in the way trying to pull down those MCP joints. But I think with careful strategic positioning, it's possible. So you're absolutely right. It's technically more demanding than a thumb inclusion. on an intrinsic minus cast, because the dorsal hood is the dominant architecture feature, and the thumb has to come off that same forearm base without compromising the hood's position or the finger MCP joint's flexion angle. So the key is building the forearm and wrist component first, getting the hood solid with your full 20 layers on the dorsum, holding all 4 MCP joints in maximum flexion, and then adding the thumb extension as a separate slab or continuation of the radial border, positioning the thumb in palmar abduction with the MCP joints flexed before you incorporate it into the body of the cast. So if you try to do the thumb simultaneously with the hood, you'll fight yourself the whole way. The web space itself needs to be filled. A small piece of padding or foam in the first web space before you apply the thumb component will help maintain that abducted position and prevent the cast material from collapsing the space as it sets. One critical check once it's done, make sure that the radial border of the cast and the thumb extension aren't inadvertently blocking the index finger from reaching full flexion. That's the pinch point on the design. The thumb and the index finger are neighbors, and so it's easy to compromise one while building the other. Shall we move into a detailed cast construction sequence so we can walk through it step by step? I think I've got that. That's no problem. I just want to know which casts can you reference for me in the literature with regards to thumb positioning, because I need to decide, am I blocking the MP joint or am I going to free up the MP joint, and will I still get IP joint flexion? All right, so now this cast reference has come up, the thumb IP joint drive cast, which is blocked to regain thumb IP joint motion. So the wrist is in 20 to 30 degrees of extension, the CMC is 45 degrees palmar abduction, MCP position selected for the deficit pattern. So it's saying, great question, and it gets to the heart of the thumb Sims decision. So the reference that anchors thumb MCP joint positioning in Sims thinking is Robyn, Midgley, and Paula Samaro's published work on thumb application within the Sims framework. And that's your most direct source, and it's referenced in the Sims Club 2026 material. So in the broader hand therapy literature, Caldert's work on thumb casting and web space management supports sustained low load stretch of the first web space and in palmar abduction as the optimal position for adductor contracture modeling. So for the MCP joint positioning decision specifically, the principle is the same as the fingers. So we're going to block the loosest joint and drive motion to the stiffest one. So if the thumb MCP joint is the stiff joint, you want it free inside the cast, so the patient can actively work on it into flexion against the architecture. If the IP joint is the loose compensating joint, that's what you will block. So the clinical question is, when M tries to flex his thumb, is he compensating with the IP joint flexion while the MCP joint sits relatively immobile? If yes, block the IP joint and free the MCP joint, and the cast drives MCP joint flexion. That would point you towards a thumb IP joint drive cast blocked for the thumb component incorporated into intrinsic plus cast. What are you seeing with the thumb movement pattern as he tries to flex? So with passive abduction, he can initiate MP joint flexion. That tells you the contracture of the adductor and the tight web space is the primary block, not the joint itself. So once you relieve the tethering by holding the thumb in abduction, the MCP joint has the mechanical freedom to move. So that's actually a really elegant finding, because it means the cast only needs to do one thing for the thumb: sustain the abducted position, and the MCP joint will find its own flexion once it's free of that adductor tethering. So you don't need to block the IP joint at all. So I'd revise the thumb component rather than a thumb IP joint drive cast, and what you actually need to do is hold the thumb in the palmar abduction within the cast, and the MCP joints and IP joints are both free, and he actively works the MCP joint into flexion as he's exercised. So the cast is doing the web space stretch and the patient is doing the MCP joint work. So that simplifies your construction considerably, and it means that the thumb extension of your intrinsic plus cast base just needs to cradle the thumb metacarpal in abduction without blocking either joint. Does that match what you're seeing clinically, and are you happy to move into the results summary and cast construction notes? So I'm going to say, can you please provide me with an updated reference in the side panel? It says, yes, let me name the other thumb cast variants for you so that they display in the sidebar. So we've got the thumb IP joint drive cast released, the thumb IP joint drive cast release plus MCP joint extension block, and then we've also got the bivalve version. So based on what you've found clinically, that passive abduction restores MCP joint flexion. So the thumb IP joint drive cast released is the most relevant one to look, and now we can see that in the sidebar, and there it is. Down to thumb injuries, you can download this playbook, and if we open it up, here you can see the stiff thumb IP joint, clinical profiles, understanding stiffness, giving you details about the clinical assessment. It's showing you the 4 cast designs. So here's the thumb IP joint drive cast blocked. Here is the thumb IP joint drive cast released. This is the one that I'm going to make with this patient. This is the thumb IP joint drive cast released with the MCP joint block, if necessary for your patient. Here it is referencing the bivalve cast, your red flags to check for, session sequencing and outcomes. So what you can expect in terms of variance in degrees range of motion gain, your cast design, post-op to SIMS, how many cohorts there are in the study, and some key clinical tips. So here are 6 key clinical tips. Do not rush CAST 2. CAST 3 exists for a reason. The weaning phase, patient education, using plaster of Paris only. To the red flags and escalation, so any precautions that you need, and your treatment roadmap to discharge. So as you can see, you really do just have absolutely everything that you need in CMMS Pro. What a beautiful mentoring session. And do follow the case so that you can see the patient live and see how he does. So do follow the case live so that you can see me casting him in his home. You can also follow him for his results and any changes that I make to the plan and the strategy.